Thank you so much, Dr. Marinier. Thank you for introducing me. I'd like to acknowledge my supervisor, Dr. Varenga, without whose guidance and support this dissertation would not be possible. The title of my research is Early Onset Preeclampsia, Uncovering the Characteristics, Patterns of Presentation, and its Effects on Maternal and Fetal Well-Being. Hypertensive disorders of pregnancy and its associated complications are an important cause of maternal morbidity and mortality, and they are third to pregnancy-related sepsis and PPH. Thank you. Preeclampsia is a hypertensive disorder that primarily affects pregnant women, characterized by the onset of high blood pressure and organ dysfunction after 20 weeks of gestation, and it is a leading cause of maternal and perinatal mortality worldwide and occurs in 2 to 10% of pregnancies. Its related disorders and preeclampsia, they complicate 5 to 7% of pregnancies and account for 35 to 45% of obstetric intensive care admissions. It can be classified as early onset, which is what we looked at in our research, which is before 34 weeks, or late onset, which is at or after 34 weeks. Preeclampsia is a significant threat to maternal and neonatal health globally. And in Zimbabwe, preeclampsia and eclampsia are the third leading causes of death after AIDS-defining conditions and postpartum hemorrhage. The seriousness of morbidity increases with earlier onset, making identification, prevention, and management crucial for reducing adverse outcomes. Our research question was, what are the characteristics of early onset preeclampsia? How does it present? What are its effects on maternal and fetal well-being? Our objectives were to identify the social and demographic characteristics of patients with the condition, to identify patterns of presentation and the known risk factors of the disease, and to identify the maternal and fetal outcomes. It was a cross-sectional study, and it was held at Mbuya, Nehanda, and Mugabe hospitals. The study population was pregnant women with the diagnosis of early onset preeclampsia and who were currently admitted at that time to either Mbuya, Nehanda or Mugabe hospitals. Convenient sampling was conducted, and it was done in the postnatal ward, early labor ward, as well as the neonatal unit and neonatal ICU, until the minimal sample size was reached, which was 96, calculated by the Dobson formula. Data was collected using a questionnaire. The questionnaire was easy to use and understand, and we also looked through the patient's notes and the baby's notes. Data was then extracted, and we used descriptive statistics to characterize the results. So what were the results of our study? 84% of the women had a secondary level education, but unfortunately 62.2% of them were unemployed, highlighting significant socioeconomic challenges. Approximately 87% of the women had their pregnancies registered, which is good news, but only 8.2% of them had booked in the first trimester, and only 14.3% were on aspirin prophylaxis therapy. 67.4% of the women received magnesium sulfate for eclampsia prophylaxis, for eclampsia prevention. And while 73.5% of the babies were born preterm, only 21.4% received corticosteroids for fetal lung maturation. The most common presenting symptoms was a headache, followed by epigastric pain, and then visual disturbances. Almost 2/3 of the women delivered by a cesarean section, and the cesarean sections were done for preeclampsia with severe features, which highlights the severity of the disease, HELP syndrome, as well as abnormal Dopplers. And 32.6% of them were delivered vaginally, either by induction or spontaneous labor. Complications, maternal complications were, most common one was HELP syndrome, which is reinforced in previous studies done as well. 34.7% of the women experienced HELP syndrome, followed by 26.6% who had acute kidney injury, 20.4% who had postpartum hemorrhage, out of which 15.3% required transfusion. Only 5% had experienced APH, and rare outcomes such as retinal detachment, the need for dialysis, and a cerebrovascular accident were rare. So in the fetal outcomes, we can see that most of our babies were born preterm, which is before 37 weeks. Only 26.5% were born after 37 weeks, but the majority of them were born between 34 and 37, which is probably why a lot of our babies didn't receive corticosteroids. In the birth weights, 52% of the babies were born above 2,500 grams, and the remainder would mainly between 2,000 and 2,500, followed by 1,500 to 2,000 grams, and then 1,000 to 1,500. The birth outcomes, unfortunately, the stillbirth rate was high. There was 8% of stillbirths and 4% equal rates of fresh stillbirths and macerated stillbirths, both being 4%, and 7% of the babies suffered an early neonatal death. Most common neonatal complication, as you can imagine, most of our babies were preterm, was respiratory distress syndrome, followed by birth asphyxia and neonatal jaundice at 9.2 and 8.2%. Other neonatal complications were abnormal Dopplers, 28.6%, although not all our babies had Dopplers done, which is unfortunate since we've got our FMU units running at Mugabe and Nehanda hospitals. Low APGAR scores were seen in 28.6% of the babies, and almost 45% of the babies required neonatal unit admission, which is quite high. 11% of the babies needed ventilation, and 6% required NICU admission. So what do these results tell us? Very few women book their pregnancies in the first trimester, which is recommended by the WHO. This may have led to a large percentage of the women not being eligible for the administration of low-dose aspirin, which is recommended to prevent preeclampsia, and we've seen that it works. The fetal mortality rate reached a concerning 15.3%. These findings resonate with studies done, other local studies done by Prof. Mbuya in Bulawayo, and they also had a notably high incidence of stillbirth and early neonatal death among preeclamptic patients. The neonatal admission rate was high, 45%, and this highlights the poor fetal outcomes. These studies further corroborate the need for timely interventions to improve maternal and especially neonatal outcomes. In conclusion, early onset preeclampsia presents unique challenges and heightened risks for both mothers and infants. And the findings of our study advocate for improved healthcare strategies, including ongoing research and the implementation of screening. We can't emphasize the importance of screening enough. Prevention strategies. Early referral pathways are also needed for these high-risk groups, as well as management protocols to enhance maternal and neonatal outcomes. These are some of my references. Thank you.